We're going to go ahead and get started since it's a little bit after 12. My name is Dr. Mel Freitag. I'm the Diversity Officer here in the School of Nursing, and we are really excited to kick off our Interprofessional Diversity and Equity series on healthcare hot topics. And so please feel free to grab a lunch, sign in at the front so we can track catering and numbers. This is the first of a series of healthcare hot topics for the semester. We plan to continue to do these, and it is a collaborative effort between the School of Nursing, the School of Pharmacy, the School of Veterinary Medicine, and the School of Medicine and Public Health. So we are a combination of students, faculty, and staff and community members here to really begin to continue the conversation today about gun violence and the intersections of that and public health. When you think about gun violence, a lot of times the first thing doesn't come to people's minds or is public health. But I think it's important to have all hands on deck and really begin to see how healthcare practitioners, professionals, faculty can really begin to see their role and how they can intervene and really start to think systematically about gun violence. So to keep things moving along, we have two fabulous speakers today that are each going to take some time for their presentations. Then we're going to have an opportunity for them to dialogue with each other, and we will give some time for question and answer after that. So thank you for coming. Please remember to sign in. Again, grab a lunch, take a look at the other interprofessional workshop series for the rest of the semester, and we are glad you're here. Thank you.
Thank you, Mel. I also want to acknowledge all the health profession school, Christy Jones, Mel Freitag, for organizing this. I'm Pat Remington. I'm Associate Dean for Public Health, and it's my pleasure to introduce both speakers today. Steve Hargarten will begin with a brief lecture on gun violence, a complex biopsychosocial disease. I've known Steve for many years. He's a professor and former chair of the Department of Emergency Medicine at the Medical College of Wisconsin. He's elected to the Distinguished National Academy of Sciences. He's a worldwide leader in the issue of gun violence, and looking forward to his remarks. Anthony Cooper joins us. He's a member of Nehemiah as an organization, and also, I have his card here, he's the executive director of FIC, Focused Interruption Coalition, and really takes a grassroots focus on gun violence as it relates right here in our own community. And isn't it telling that some of you may have gotten an email that as we speak, there's an incident on the west side of Wisconsin where shots have been fired, and guns are certainly ever present in our community. So what we're going to do is ask Steve to talk for about 20 minutes, and then Anthony will join us here for a conversation between the two of them, and then we'll open it up for the final 20 minutes to you for questions. So welcome, Steve.
Thanks, Pat. And thank you all. It's an honor and pleasure to be here to talk to an interdisciplinary group. As an emergency physician, I interact with nurses, pharmacists, technicians. It's supposed to be on. It's green. Can you hear me now? Okay, good. And so it's a great pleasure for me to talk about gun violence in this context. I'm going to be going through these slides fairly rapidly to get to the conversation with Anthony and with questions and answers from you all. And this is, there we go. So our goals for today: frame violence as a complex disease, define our roles and responsibilities. We're going to talk about that more in the discussion period, and advance the science of injury prevention and control. We don't want people getting injured. That's our goal. Just take a seat, Mr. Byrne. You're acting as if you were the only one who's been shot. This is happening in urban centers largely in a frequent way. It's happening regularly, and now it's happening right now as we speak. This is our index case. It's a gunshot wound to the chest. I guess the pointer just, there we go. That I describe as a lead infiltrate. It's not pneumococcus, it's not staphylococcus, it's a lead infiltrate adversely affecting our patient who's been exposed to kinetic energy from the bullet. These are the viruses, bacteria that are invading our patients with their kinetic energy. This one in particular is nasty. This is a black talon bullet which actually rips through tissue additionally as it opens up upon penetrating a victim. We felt in the 90s when this was introduced, it's an unacceptable virus being introduced into our community. Think about that kinetic energy exposure impacting the humerus, damaging it now with this individual having lifelong disability. And in understanding this as a disease, we better take care of patients. We didn't do well with this patient. The kinetic energy impacted the femur, shattered the bullet. Where did the rest of the energy go? It went into the femur. We didn't see the fracture. We didn't treat it as a suspected fracture, and it went into a full-blown fracture with that corresponding disability as well. By understanding this process, understanding the disease process of gun violence, we can take care of patients in a better way that's science-driven. And here's the permanent cavity that's formed when the kinetic energy passes through the liver, expands in the temporary cavity, resulting in that permanent cavity. Knowing the dynamics of this injury event helps the surgeons and the critical care nurses take better care of this patient for perhaps a critical observation period rather than an operation. And by understanding some of the dynamics of this gunshot wound of entrance and exit wounds, we better understanding what happened. This individual is a police officer who was taking her gun out and shot herself. And we've had individuals come to the emergency department with this pattern, 17-year-old who says, oh, somebody across the street shot me. And we go, wait a minute, this didn't happen. You were pulling the gun out of your pocket and shot yourself. Important for the other aspects of this disease process that involves law enforcement. So briefly, the history of this in the way we frame it, gunshot wounds are named as evident from the manner in which they're produced. This is a long time ago. This guy, Dr. Hunter, if the velocity of the bullet is small, then the mischief, I love that, the mischief is less in all of them. There's not so great a chance of their being compounded with fractures of the bones. He was understanding the kinetic energy dynamics of the bullet. But if the velocity is sufficient to break the bone and hits, the bone would be much more splintered than if the velocity had been very considerable. For where the velocity is very great, the ball, as it were, takes a piece out. However, all this will be very accordingly to the bone. This guy is trying to do this in 1700. So fast forward, the dynamics, the pathophysiology of this disease, as the bullet moves through the body, it crushes and shreds in its path while at the same time radially flinging the surrounding tissue, stretching and tearing as the bullet's kinetic energy is transferred to our patient. And it's a combination of the crushed and shredded tissue and the effect of the temporary cavity and tissue adjacent to the bullet path that determines the full extent of the wound. You saw that in the CAT scan of the liver, that permanent cavity formation. This is the biology of this disease. And the location, size, and shape of the temporary cavity depend on the amount of energy lost by the bullet through its tissue. So it's the kinetic energy that's damaging the tissue, the kinetic energy from the bullet. That's the pathophysiology of this disease. And what's challenging about this is that it took place in less than a tenth of a second. Bullet's gone. It's out there somewhere that they were shot. And we see the after effects of that kinetic energy exchange. That's an entrance wound for the bullet as it penetrates the tissue, forming that permanent and temporary cavity. And place this in the context of medicine and healthcare. I read this article on sepsis, which is a biological injury. And at the end of the pathophysiology section, describing the complexities of sepsis from a bacteria, this paragraph just jumped out on me. Alarmins are also released during sterile injury. A bullet penetrating an individual, a patient, is a sterile injury, not a biological injury from a bacteria, from a virus that's injected by a contaminated needle. And it's really important to frame that, such as trauma, giving rise to the concept that the pathogenesis of multi-organ failure in sepsis is not fundamentally different from that in non-infectious critical disease. Fundamentally important for us to shift our thinking about gun violence. So I want to frame this in a way, and I've really taken liberty with Senator Moynihan, Guns don't kill people. Bullets, kinetic energy kills people. And it's important for that science to be discussed without it being disproportionately, behaviorally explained away, which discounts some of the other elements of this disease. And Senator Moynihan stated this 25 years ago. I've just been framing it recently, and I thought, well, I'm in good company with Senator Moynihan. So the disease model has evolved. In the 1800s, it was your own fault. You didn't believe in God. You're a Protestant. You had bad smells, evil spirits. And as we know from the 1800s, in that seminal work in London with John Snow and Robert Koch with Koch's postulates of disease processes, we know that there's got to be a cause of the disease. What is etiology? Anthrax, tuberculosis. The mechanism of its environment, the pathogenesis. What happens to the organs once it's infected with that biological injury? What are the structural altercations, the morphological changes, and the clinical significance? That was taken on seriously in the late 1800s, 1870s, 1880s. Louis Pasteur, Robert Koch, and others. That's where science began to inform, in this case, infectious diseases. So this is a vector carrying an agent of disease, a biological injury. So the etiology in this case is a vivax or falciparum parasite. The pathogenesis, you can see the morphological changes and the clinical significance. Classic disease process, fully understood in the late 1800s, early 1900s. Malaria is Italian for bad air, because that's where they thought malaria came from, bad air. And we then, with science, advanced our understanding with mosquitoes carrying that parasite. So for injury, trauma, injury, it's a disease process, and we're going to discuss primarily kinetic energy, car crashes, fall from heights, bullets penetrating individuals. The pathogenesis is an acute exposure, milliseconds. We know that because we've studied it. And the morphological changes and the biology of this resulting in the clinical significance we see in healthcare systems with fractures, hemorrhage, subdural hematomas, shock, and death. It's a disease process. Its distinctive feature, one of them, is that it happens in less than a tenth of a second. And this process that occurred with the bullet transversing the liver is happening in less than a tenth of a second. And the individual then is resuscitated and hopefully recovers from the biological issues, but we haven't addressed the preceding psychosocial antecedents that puts that person at risk and the subsequent psychosocial issues that put them at further risk of not fully recovering, framing it as a biopsychosocial disease. So in that case, when it's framed as a disease, it opens up public health strategies. We don't limit our interventions for malaria with telling kids to be safe around mosquitoes. We put nets around them at night. We look at the water sources and get rid of stagnant water. We look at the mosquito and wondering, what can we do about the mosquito that will reduce its carrying of this parasite, and perhaps there's a vaccine against vivax. And so for gunshot wounds, the agent is kinetic energy from the bullet. The vector is the gun, carries the bullets, maybe 10 at a time, maybe 15 at a time. And the environment is the environment of Madison, the environment of Milwaukee. And the host patient is a 20-year-old male, and Anthony's work informs that person at risk when they get shot, and we're going to hear about his great work. And what's the appropriate care of that 20-year-old male in the hospital setting that's beyond the biology of this disease. So it's a biopsychosocial component that we need to understand so that our management is better, and it's not limited to a biomedical model of, oh, your liver is fine, you're now able to be going home, good luck. It's more than that. It's a complex disease process that we need to do better. So the biology, social context, and psychological antecedents and outcomes that affects patients, families, and communities, that behavioral component is where Anthony and his work is concentrated as part of a broad public health approach. And that's going to be our discussion primarily today with our limited time. But you can understand there's other discussions, the environment in which this individual comes from and the agent and vehicle or vector. So the utility of framing this as a complex disease process is that it's science-driven. New England Journal of Medicine, sterile injury. That it pulls in healthcare systems and leaders, and all of you, as nurses, pharmacists, and other professionals, will be leading healthcare systems to do a better job with this disease process. And informs injury prevention and control that gets us out of the hospital into communities and partnering with Anthony and his group and others to do a better job with our patients and in the context of the communities in which they live. And this paradigm shift is important because it really is becoming our 21st century disease challenge. So finally, in some summary quotes: responsibilities of physicians and other healthcare system leaders. Internal medicine and pediatrics have taken a progressively wider view in the areas of social responsibility, the one reaching deeply into physiology and biochemistry, and the other branching out into the field of genetics and prenatal diagnosis. For the study of injury, surgery, and I've taken liberty with his quote, as he's a surgeon, emergency physician, that's where I come from, pediatrics, nursing, I added that because of this presentation. It's nursing leadership that's critical. And the healthcare systems. We're going to be discussing this at the National Academy of Medicine next month, of pulling in healthcare systems legitimately, must likewise broaden their focus to include social, environmental, and political disciplines. Gun violence is a complex political disease. There's some areas that really need to be thoughtfully broadened, so that the political disciplines that have not been formally been considered a concern of the physician and healthcare systems. If physicians and others fail to broaden their scope and social vision, their future will be stunted, and our understanding of injury will be faulty, limited, and ineffective. Don't know what's going on. Running out of gas. There we go. So the world, and I've taken this quote from Anthony Cooper with his email, and I found it to be appropriate to end with this as Anthony comes up, is the world as we have created it is a process of our thinking. It cannot be changed without changing our thinking. And the science-driven is changing our thinking. How do we understand this disease process? Malaria, it's not from bad air, it's something else. Really important to see that happen. I found this to be a very timely quote. So things have changed. I used to smoke. I mean, what is this? You know, Lucky's. I had a Lucky's. It's toasted for your throat protection against irritation. What? I'll end with that. So I know we've got a little time I wanted to go through this pretty quickly, but just wanted to get this framed up and teed up for Anthony in our discussion about gun violence as a complex disease. So thank you very much. Oh, okay.
So what I'd like to do is entertain a dialogue between Anthony and Steve. This began earlier today. We actually met for an hour before lecture, and I encourage you guys to continue some of the great conversation you had about the contrast, really, from Steve, who is an emergency medicine physician by training, public health training, views this in a public health context, and briefly gave us an overview of his perspective, to Anthony, who is literally receiving a text message about this event here in Madison and may have to leave, by the way. So your perspective on sort of gun violence as a biopsychosocial disease.
Hello, everyone. Well, the way I look at it is that it's really fueled by trauma. There's trauma that what people are dealing with. I mean, from newborns to, and still dealing with when they get into middle school and high school and so forth. And people not being able to really work together as a community, and for us all to be able to work together. That's kind of where a little bit of how I guess my approach is. I think one of the things that what we were talking about a little bit earlier, as far as like why are the shots being fired, why are things happening? There are people that are in the community that are basically are hurting and don't know how to necessarily deal with it, don't know how to address it, or even have the conversation and be able to talk to even just to seek help. So in that, we're trying to figure out different ways of how we can work together as a community. One of the things that what we kind of addressed was how can we prevent the trauma that is actually happening in the hospital setting. There are times when shots are being fired. A lot of times some of the nurse staff, or even doctors or even social workers don't necessarily know how to work with people in the community. And by that, it kind of allows us to be able to just step in and really have those real heart-to-heart conversations and navigate that system.
So I might ask you to just briefly talk about your own perspective and, growing up here, from Chicago, but growing up in Madison. Why has gun violence become sort of a public health issue from a criminal justice issue in the past, but now your thoughts about viewing it as a public health issue and a community health issue, and your role in your organization confronting it?
So, again, back to, first off, it really all stems from trauma. If you're not being helped along the way or being shown, and I don't want to necessarily say helped, at least being able to shown another path of doing things in the community, whether if it's looking for employment or whether if it's trying to better yourself. For most, and I'm sorry, let me kind of retract just a little bit. I kind of start off with myself. I always use myself as being pretty much a living testimony of my own life, right? So for me, I was considered a man-child. I was a kid who pretty much I was trying to pay bills at home, trying to take care of my mom. That wasn't something that she wanted me to do, but that was something that where when you start to notice some of the things that are happening, it was one of the things that where you kind of jump in and kind of say, you know what, let me try to help with this, whether if it's a bill, whether if it's, now at this point, I was actually 8 years old. I was trying to basically help my mother pay rent. The landlord took notice, was like, oh, okay, this young man is trying to provide, but not even necessarily knowing what it was to really provide, but at least try to add that assistance. So now in some sense, for some, that can be really traumatic, and, because it wasn't like I can really provide. What can an 8-year-old kid do? Realistically, except I asked my landlord to say, hey, is there a way that I can clean the apartment units or clean the hallways, and for him, he really took a hold of that. It was like, oh, wow, let me try to figure out something for this kid that's trying to basically be an adult. So if we fast forward for myself, eventually, I worked different jobs, but at the same time, I didn't necessarily get it. It wasn't about money. In some sense, it was more about money, but not necessarily about the way about getting it. So eventually, I ended up leading a life of crime. I ended up going to prison. Went to prison. Decided to, once I got home from prison, to basically change my life around. Everything for me was really based on, because I know I'm trying to cut some things short because of the sake of time, but really, for me, it was really, I want to be able to provide differently for my sons. That's what it really came down to. Wanted to be able to give them a different life, and originally I went about it the wrong way. But when I came home, I was able to change that way around. To eventually end up I started off when I came home from prison. I worked at Papa John's Pizza. From working at Papa John's Pizza to being able to work in a warehouse, then eventually being able to work. I got my first professional job as doing job development for the Department of Vocational Rehabilitation, and then allowed that to grow. And then eventually I ended up owning my own business. I did that for about 8 years for being a state and government contractor. But one of the things, because of my I guess from my own experience, that I was able to see some of the trauma that what other people were going through, but then also I knew the brokenness that what men and women were going through, not being able to find a job, not being able to find housing, and many of us, including myself at that time, was pretty much just went about it the wrong way. But once you're able to show people a different way of being able to do things the right way, but also being able to follow up and ask questions, and that's saying that people are looking for a handout, but they're looking for a hand up.
Makes me think, Steve, from the perspective of Anthony's view, how have you seen emergency medicine, or I should say, has emergency medicine in the healthcare system evolved to engage the community along this continuum from what you do in the hospital during the event to how you might think about prevention, and particularly focus on here in Madison, what might we do with engaging communities to have a more holistic, comprehensive approach?
Sure, and it's really interesting, and just as reflecting on Anthony's comments, just a sidelight story to bring it up to full speed. We are interacting with West Dallas, which is a smaller community outside of Milwaukee, but it has a violence problem. And we engaged with a police chief who I worked with 30 years ago at St. Mary's Columbia, and he was a tech. He went on to nursing school, psychiatric nursing school, police, and he was the chief of police in West Dallas. He instituted a program where if the police arrive at a home with children, and they come with 17 reasons that get to the trauma that Anthony just referenced, they send an address to the school. It says all the address is that the school knows that the police visited that address the day before for one of 17 reasons that are related to adverse childhood events. See, Johnny's not in school today. That's where Johnny lives. What's happened? Actually, Susie, who's in second grade, is in that address, and she's acting out today. And having that collaboration led by a nurse who became a police chief is really fascinating for me as a public health person to think broadly about engaging all sectors of civil society, in this case now police and schools. So from the standpoint of Dr. Remington's question about healthcare systems, we've been engaging what's called a Cardiff model. So when we have a patient who comes to the emergency department and they're injured, or a child, or a 10-year-old, we take in all this information about how old are you, what did you get injured with, okay, when did this happen, okay, great. But we don't ask the question, where did it happen? 35th and Burleigh, 11th and Burleigh in Milwaukee. I know that because my great-grandmother grew up there. What's happening at 11th and Burleigh? And getting the nurses to get that information has been a fascinating display of culture. So the nurses at Children's Hospital, got it. We're getting it. We're getting this information. We're doing it. Great. We are actively engaged in the community to prevent assaults and injuries and violence. The nurses at Children's think differently. The culture is different. And the public hospital in Grady, which was also incorporating this Cardiff model, which uses that assault location information to geospatially put on a map going, well, what's going on in this area that's now had assaults? In Grady Memorial Public Hospital, they embraced it right away. The two community hospitals that we're working with, the nursing staff, yeah, I think this is important. Yeah, I think we should do this, and they've been coming along steadily. Brainerd Hospital, where I work, and the nursing staff are terrific in taking care of a patient. Their initial reaction, hey, come on, that's their problem. We don't have anything to do with the community because that's not our job. And we want to change the culture of the healthcare systems to be thinking about their role in informing where these assaults are occurring to prevent a unleashing of a more serious amount of kinetic energy from a bullet from occurring. So the pulling in of healthcare systems is, in my mind, fascinating. Early adopters, innovators, children's hospitals, to healthcare systems. Yes, I think this is the right thing to do. To engaging Anthony and his group when a gunshot wound victim comes to the emergency department, and engaging this to help with the family and relatives, and engaging the community after the math of this energy release. To others who are going, what is this? Why am I here? That's not my job. My job is to patch up the biology of this disease, not the psychosocial aspects of it. And so we're thinking about hiring a clinical psychologist in the emergency department to complement the nursing team, the technician team, the x-ray team, the surgeon's team, and all of that to help respond better and collaborate with groups like Anthony to strengthen our broad approach for these patients. So the healthcare systems have got a long ways to go, and we're hoping to see that change that's real in their engagement, their authentic engagement with the community, and they're not handing out, I'm cynical, they're not handing out pamphlets, they're not going to healthcare fairs, and I'm just wondering about what goes on with those. So I think that's an important element that healthcare systems need to examine.
Something I just want to add on to that, like I just heard what you had said, as far as how the nurses team and things of that nature would kind of say, hey, this is not what we're here for. So just by show of hands, if it's okay, how many people in here are nurses or going to school for nursing? Okay, awesome. So I guess I don't want to throw it out as a question because quite a few of y'all, but I'm just thinking that so in my world of things, I would say someone who is a nurse, you're a community servant, just like no different from a police officer, no different from a fire person, a fireman or firewoman. But I think at some point, and I think Frater is trying to change the way how people are looking at this, is saying like, look, we're all here for the community. Because if you're going to work in a community, you have to really indulge yourself in some part of the community. Because if you don't, it's always going to be us and them. Always. You're never going to, if I was to come in with a gunshot wound, or if my family was to come in, you're not going to necessarily know how to at least talk to them and have a real conversation. And so that's where we come in as far as community people that also, again, community servants, to say where we help people navigate that system. So where if you don't want to necessarily talk to the whole family, then someone like myself will come in and say, all right, what's the next step from here? Because there's times that where I'm dealing with a victim's family, that where they're sitting in a waiting room for an hour, trying to figure out whether or not if their son or daughter is alive, or even sometimes even trying to figure out if that is he or she, if that's my child. So just think about the trauma that happens behind that, and think about the way that where if it was your family member, you're still trying to figure out and how the not only the trauma, but then also the trust that was going to take for you as a community servant, but then also us as community servants as well, to be able to help people navigate that system. But it also, more than anything, it takes teamwork, because this is our community.
So, Steve, before we turn to questions, just a few more comments. You talked about your work over the last few decades and the importance of a comprehensive approach. In fact, even when you began to look at firearm injuries, your comprehensive approach of including all parties. Can you talk about that and the fact that maybe this isn't us against them, but really society thinking about solutions?
Yeah, sure. The background of this was that in car crashes were major issues in the 50s and 60s, and there was a paradigm shift of our thinking. I'm hoping that that's happening with gun violence now more and more. And one of the things that happened was they established a fatal analysis reporting system. Every death is comprehensively linked and compounded with data to better understanding the distribution of deaths and do a better job of reducing those deaths. We modeled that FARS after a editorial was written in JAMA to see if we can combine the information on gun violence, because it's never really been done until the 1990s, where we took the information from police, from the coroner, which is the medical examiner, which is the healthcare portion of this, and the crime lab, which I find is the laboratory for this disease, combined the information in a comprehensive way. And Milwaukee County was the first county in the United States that ever did this as a model to better understand what's going on with these deaths, what kind of guns are linked with those deaths, what are the circumstances of those deaths, that are combining information. Police information is who, they're combining information for who's wrong, who's the crime person involved in this, not for preventive health, not for public health. By combining it together, we established the firearm injury reporting system in Milwaukee, southeastern Wisconsin, and it served as a model for the National Violent Death Reporting System. That's CDC, and Wisconsin is one of the first states now that is linked with CDC and has a comprehensive data system to look at these deaths in a way that's never heretofore been done, and it's been beneficial. So it's a great example of combining information to get better information, and Cardiff is a non-fatal approach to that. By getting that information out, we convene sectors of civil society to discuss what's going on in these areas of our neighborhood, in this case West Dallas. We've had discussions to have this in Madison to help understand, well, how can we prevent this? How can we do a better job in the community that helps prevent these assaults from occurring and result in preventing injuries? And it's science-driven and it's community-driven in a way that helps make those communities better. And when it was incorporated in Cardiff, Cardiff saw a 40% reduction in violence. Evaluated rigorously, and we're trying to translate that here in the United States.
Just one quick follow-up question for you. You described this morning your role actually in a setting where there had been a firearm injury and the importance of that event and your work with a large extended family and friends, and maybe intervening at that point with a young man who might have taken action, and your role in preventing that.
So what he's referring to is that there was a shot fired incident that happened. Someone was at the hospital, so of course, family and friends, everyone is concerned and worried about their family members. So the next thing it had to be either between 50 to 65 people that were who showed up to the hospital. Now, with that many people coming to the hospital, if the hospital didn't have the community support from our organization at Nehemiah, as well as the Focus Interruption Coalition, so when shots are fired, they call us, and then we come just to work with the families. But Madison is a small community. I feel is a small community. So we were able to work with every single person there. But if we had not been there, there would have been people that would have went to jail that night. There would have been, and all of it is acting off of trauma, off of emotions. There's times that where, and this is a young black man that where, even though he didn't necessarily, he didn't threaten anyone or anything of that nature, but I think the fact of where, he was very loud, but he was hurting, and didn't know how to have that conversation. So myself, I grabbed him and, really went for a walk with him, went back to the hospital. But if we had not been there, he would have went to jail, and not only himself, but quite a few others.
We were talking about this earlier, and I think this is a great case example, but we want to replicate this at Freighter. We want to replicate this good work, because that is a way to strengthen the healthcare system's response, is actively engaging a community partner who helps us manage the acute phase and the subsequent ripple downstream effects. I think it's fantastic.
Well, that's great. Thanks, Anthony. And it's an opportunity here. We have a national expert on research and advocacy and a local community expert on really boots on the ground with his organization to address this issue. So I'd like to open it up for questions. And you can just shout your question out, and I'll repeat it. And there's a mic back there. Mel has a mic if you want to use that. So encourage you to take this opportunity to ask questions.
Hello. Oh, yeah, you can hear me. My question is just how widespread do you feel this type of collaboration is across the nation?
I can say that there is now a national organization of hospital-based violence prevention programs. Project Ujima at Children's was one of the first in the country, mid-90s. And so there is that growing body, largely led by urban hospitals, trauma centers, and that is increasingly happening. And now, which is exciting, is Kaiser Permanente, a large healthcare system, is dedicated $2 million to research gun violence. A healthcare system doing this is unbelievably game-changing. And I think with the National Academy of Medicine discussion in October, we're broadening that, and that workshop discussion will hopefully pull in more. So we're in this critical stage where there's about 15 to 20 hospital-based violence prevention programs, some of which could be strengthened by the approach that Anthony's group does. Others are doing great work, so that's just in a fairly early stage of healthcare systems being actively engaged. Great question, because that's a missing link to addressing gun violence in a comprehensive way.
And I guess I can add on to that as well, as far as I think that we're, especially with the hospital system, of being able to show them that, hey, let's stop the separation. And again, we have to be able to work together as a community. There's hospitals in every community. So if you do not have direct ties to the community when things happen, then you're going to always, it's going to end up in a mess at some point or another.
Great question about...
Just repeat the question.
Yeah, why clinical psychologists versus psychiatric social workers? I'll get to the bottom line real quickly. Clinical psychologists can charge for their services and can supervise the social workers. The social workers we have, I can't say enough of what they do for patients. And expanding that ability, clinical psychologists can also do brief interventions in the emergency department for alcohol abuse and misuse, and other avenues. It complements the team rather than replacing anyone. And so we look at that as a complementary approach. Psychiatric social workers, boy, more and more would be fantastic in the ED setting for the complex, again, biopsychosocial disease presentations that go beyond a gunshot wound and those things. So it would be great to expand the team. And for those of you in pharmacy, we added pharmacists to our team 24/7. It's unbelievably effective. I was raised with a PDR, physician's desk reference, and to look up the drugs. And the pharmacists are unbelievable, and it's all right. So complementing that team, I think, would be fantastic, and broadening it to make it effective. But the bottom line too is that there's a bottom line for the hospital too. Is there's revenue. We charge for these services, and I think that's an important element to work out. So it's a great question to complement the team.
Along with the psychologists that are obviously needed in the ED, I feel like I'm really loud, sorry. I was shadowed in the ED last Saturday at Meriter and saw many times where people were told to follow up with their primary care provider and they don't have one. They either have Medicaid and said that they were unable to find a provider in Madison or didn't know how to. So I'm just thinking about this trauma.
Go ahead.
Yeah. All right.
We have 3 hours for this discussion.
Right. Yeah.
Clarify this.
I love that you said that, because a lot of times that's what we face actually when we're at the emergency room. But again, I think for our organization is that we actually help people navigate that system as well, because of course you have like Access Community Health. There's another one that's here in Madison, but it's still Access Community Health. I was on the board of that. That clinic, so it was easier for me to be able to help people to go through that clinic. So that's a constant struggle, because some people are dealing with issues that they don't necessarily know that they're dealing with, and don't know how to have the honest conversation. Because at the same time, if I'm coming to an emergency room, and if I don't necessarily know myself, but then also I don't know you. I don't know how to build that relationship with you within that 10, 15, 20 minutes. You know, I want to get whatever that need is that need met. But other than that, there's so much more that could be going on with that person. And so it's really kind of tapping into them a little bit deeper, but you have to have the right people on staff there 24/7 in order to even get that close to someone who can ask the hard questions.
So you've asked a critically important question, and I can see Anthony Cooper being a top-level hospital executive in about 10 to 15 years, because that's exactly where we need to go. When I joined the faculty in 1989 at Fredericton County Hospital, I was just told the story this morning, I was staffing one of the residents who was dutifully reporting the injuries to a woman, including the x-ray findings, which were negative. She was going to discharge the patient. I said, well, great, that's a really nice summary. What happened? He said, I don't want to know. You mean you don't want to know what happened to your patient? She didn't want to know because she didn't know what to do with it. There's no system of saying, you know, you've experienced domestic violence. Here's resources for you to go. In fact, the nurse is going to come in and talk to you extensively about it. And that's changed. We need to change our approach to these patients more and more with psychiatric social workers, clinical psychologists, and others, and a system of care that says your appointment is in 2 days. And in fact, a community health worker is going to be with you to go there and shepherd you through that. We're not doing that as healthcare systems uniformly, and I think some are getting into that more and more, but that's a critical healthcare system transformation that is slowly occurring. With that question earlier, there are now hospital-based violence prevention programs. There's now, for emergency medicine, there's social emergency medicine. We're getting into this, what are we going to do? And the rate-limiting step is, we don't know what to do about those social determinants with that 10 to 15 minutes. We want to do more, and we need to engage our community leaders to credibly do a better job. Great question.
My question has to do with collaboration as well. A lot of the higher violence or higher profile gun violence incidents happen at schools and college campuses. So how does the public health approach to this coordinate or involve school districts and higher ed institutions?
I was talking to Dr. Remington, who's actually an expert at investigating outbreaks. Biological outbreaks. E. coli breaks out in a food or a restaurant, and you have a response. There should be a response to school shootings that's public health oriented. It's a kinetic energy outbreak. That's what a mass shooting is, in my opinion. And looking at Las Vegas, looking at Parkland, and talking about it in the visceral way. These organs are ripped open. And there is this response that tends to be limited, but not comprehensive. And we don't do a good enough job of collaborating all the players. So when Texas had that one of their shootings, nobody from public health was there to inform the discussion about how do we do this in a comprehensive way. So we've got a lot to do. Sandy Hook, I thought, was going to be a game changer. And it got pretty far, but didn't change it the way many of us thought. So that collaboration has to occur more and more, and it's still limited to a broad public health approach rather than a criminal justice approach, rather than something else. Why can't we identify this disgruntled kid who is failing, who's isolated, and pull them in before it happens. And I think that's where we don't do a very good job at all of identifying high-risk individuals who are at risk of making a poor decision. And a lot of these are murder-suicides. Very complex, but we're not investigating, in my opinion, the comprehensive way. Again, very good question, and we got a lot of work to do.
Hi, thank you both for presenting this really important topic and obviously very relevant, especially today. I really appreciated your comment about gun violence being a political disease, and I'm wondering if you had a political magic wand, what would you change, create, or remove from public policy to help prevent gun violence? And also in that, if you could just provide any words of encouragement or advice to our aspiring health professionals about their role in being politically active to help prevent gun violence.
Again, we have 3 hours, is that what? Right. So first of all, it sounds very trite, vote. It is so important to be actively engaged in your community from a simple vote. Get out the vote and vote for policymakers who want to make a difference in their communities and challenging them to make a difference. So first and foremost, as members of civil society, get out the vote. The NRA is a association that was started in 1871 for 2 reasons. Marksmanship, because the Union Army was so bad, and safety. So when my work with the NRA has been to pull them into a discussion that is common ground. Gun safety. That's an area for initiating a discussion. And the NRA is just a group of 4 million individuals. I've met many lifetime members of the NRA who are very, very thoughtful, reasonable, and want to advance good policies such as comprehensive background checks. So we've got some opportunities, but again, science-driven about the behavioral issues that we want to make a difference, and having those common discussions. And suicide becomes a common ground as well for getting all parties together. So it's a matter of respecting and having good conversations, science-driven. The NRA are not public health experts, and they need to be clearly told that. This is a public health discussion. And I think that's important if we frame it to have them placed properly in the discussion and respectfully tell them this is great, but you're not a public health expert. And I think that these are some of the things that I've learned over the years is these are individuals, a lot of them are well respected and have an area for contribution. But it gets dicey about the kinds of guns, and that's a whole different discussion about gun safety, where we need to take the NRA out of the picture and bring in the gun manufacturers. The gun manufacturers are the target of discussions, like car companies were the target of discussions when we transformed motor vehicle crashes as a public health problem in the 1960s. So that public health approach is very, very important to take when we're dealing with a lot of different factions. And the Wisconsin Tavern League, many of you know, is very powerful, and yet we got smoking out of taverns and restaurants. So it's hopeful that by framing it properly, we can make advancements in policy and discussions. So it's hopeful. Don't lose sight of the fact that the target is healthy and safe communities. What? You're not for healthy and safe communities? What? Come on. Healthy and safe communities. That's where we're going. Together. How do we do that?
If I had a wand.
Yeah.
So I definitely agree with a lot of things what you said, but I also think that I'm kind of in favor of getting rid of guns at some point. But then also, I know that they're definitely necessary, but I think that the education about guns and things of that nature need to happen a little bit more. But then also, I feel that for health professionals, I think they need to really understand the community that they work in. and not in such a way where it's like, hey, okay, you do this class, then you're meeting someone in the community, you have a community rep, and kind of go from there. But really understanding the community, and whether if it's working in the community, but then being involved in the different community spaces that allows them to see what the heart of that community really is. I think that would change the dynamic not only for the health professional, but then also for the community as a whole.
So do you know if these similar organizations are needed in other countries, like in Europe or anything? And if not, do you know why it's so significant in America?
So the death rates from gun violence have significant differences. In terms of industrialized countries like Europe and the United States is way, way, way above those countries. Other countries are very high in death rates from guns. And the Americas, Central and South America, are suffering from gunshot wounds and gun violent deaths. And so there's a lot to learn internationally from this. The Cardiff model was in Cardiff, Wales, and we are transporting that into the United States. It's been shown to be very effective. So we have something to learn from other countries and other cities. But other cities are grappling with this, and they're grappling with the small p politics and complexity of this in their respective countries. It's over 40 cities. In terms of the Americas, the Americas dominate gun violence globally. And so we've got a lot of work to do in cities like Rio de Janeiro, Medellin, and Chicago, and so forth. So we're actually convening a panel on this very subject in March in Chicago with the Consortium of Universities for Global Health, because we feel this is a global issue of this kinetic energy traveling all over and inflicting wounds and killing people. And so trying to get that understood and learning back and forth will be very, very positive and helpful.
There's none right now in Wisconsin. Well, I guess in Milwaukee, what they have at UJAMA, but they only work with youth. In Chicago, they also have, I forgot about them, there's the Ceasefire is also another organization that do similar work, but I don't think necessarily they have the connection with the hospital. It's pretty much going door to door and knocking on doors and trying to figure out different ways how we can work together as a. But I think that more and more organizations are starting to pop up a little bit more because, we have to really start, again, it kind of goes right back to us working together as a community. We have to get this thing done, fixed in some type of way, being able to help people kind of not only navigate the systems that are in the hospital, but then also navigates the systems within themselves to basically get some type of balance a part of their life.
I think that's a good way to end it today. I know there are more questions. I think they'll be available for a few minutes after the lecture today, but let's thank them for coming.